Good afternoon and welcome to the Reducing Complications While Sharing Financial Risk, a New Era of Vascular Closure webinar by Dr. Barry Bertolet. My name is Mike Gebauer. I'm the Director of Global Marketing and Training for Cardiva Medical, which is now part of Haemonetics, but more about the company in just a moment. Today's agenda is robust. Roger Owens, the Vice President of Commercial Sales, Marketing, and Business Operations with Haemonetics, will share a little bit about the company. Dr. Bertolet will review clinical data, discuss technology, share several short case videos, and describe how their program focused on reducing complications and sharing financial risk. Now I'll explain the format of the Zoom call today. All Zoom participants will be on mute during the presentation portion. However, feel free to send your questions and comments via the chat function within Zoom to Roger Owens, who will gather questions and ask the speaker at the end of the presentation. You'll see instructions for sending a message through chat at the bottom of each slide, so don't worry if you didn't remember exactly what to do. Now, I'll hand the microphone to Roger Owens. Roger.
Thanks, Mike. I'd like to thank everyone and welcome everyone and all the webinar participants today. And as I stated, my name is Roger Owens, and we're pleased to host Dr. Bertolet as a key luminary in the field of interventional cardiology. And prior to introducing Dr. Bertolet, I'd like to provide a brief overview of Cardiva for those of you who are unfamiliar with Cardiva, now a company under Haemonetics. So our mission predominantly has always been to reduce access site complications. That's kind of the why we are here, which has helped to enable earlier ambulation and then same-day discharge while providing risk-sharing agreements with some of our top customers across the country. And you'll hear more of that during Dr. Bertolet's presentation. So primary products, for those of you who don't know, we have Vascade, which is 5 to 7 French arterial and venous closure. And then we also have Vascade MVP, which is 6 to 12 French inner diameter, 15 French outer diameter, and that's on the venous side. So, Cardiva has been a rapidly growing company, and we've been focused on predominantly vascular closure, and that's where our field of closure experts spends their time and energy. And recently we have become part of Haemonetics, which is a $1 billion a year medical device company based out of Boston, Massachusetts. They have 3 primary divisions: a blood division, a plasma division, and then also a hospital division. That's where Cardiva reports up to with Stu Strong as president of the hospital division. So for those of you who don't know Haemonetics, the primary products out of the hospital division are TAG and Cell Saver products. So some of you may have heard of those in various hospitals. So today we're privileged to have such an outstanding speaker today and physician, as I shared with Dr. Barry Bertolet, and he is an interventional cardiologist at North Mississippi Medical Center in Tupelo, Mississippi. He's really been a luminary in the field and a person that I'm proud and privileged to say I've known for quite some time. But Dr. Bertolet has received his bachelor's degree in chemistry and completed his medical studies at University of Mississippi. And then he completed his internship and residency at the University of Florida in Gainesville, where he also received postgraduate training in adult cardiology. And really, throughout his medical career, he's been the recipient of a lot of different honors and awards. He was selected and enlisted in Best Doctors in America and had been the recipient of the Teacher of the Year Award at the University of Florida and North Mississippi Medical Center. He's also been the recipient of American Heart Association Research Fellowship Award, and he's been actively involved in over 50 scientific publications in the cardiovascular space. And as a side note, Dr. Bertolet in North Mississippi Medical Center was the first center to actually participate in Cardiva's risk-sharing programs nationally. That happened in April of 2016, to give you a little bit of timestamp on that. And he was one of 5 investigators for Cardiva's Integrate Registry trial for critical limb ischemia patients, where we were evaluating safety and efficacy of that high-risk patient population. So finally, Dr. Bertollet has been elected chairman of North Mississippi Medical Center since 2017. He's currently the vice president of Mississippi Healthcare Alliance and was actively involved in the design and development of the statewide STEMI system of care. Joined North Miss medical staff in '97, and North Miss, for those of you who don't know, has been the recipient multiple times for the Baldwin Award, which is the highest award for quality. And it's quite an honor for a hospital to receive that once, not only multiple times. So with that, I just want to say welcome, Dr. Bertollet. Thank you, and looking forward to the presentation this afternoon.
Thank you, Roger. Appreciate the invitation to be here. And again, as Roger alluded to, I am from North Mississippi Medical Center. Claim to fame is that Tupelo is the birthplace of Elvis Presley, and we're the largest rural hospital in America. As Roger mentioned, we are a 2-time U.S. Conridge Baldridge Award winner, and we're also been last several years now an IBM Watson Top 50 Cardiovascular Hospital. We serve a population of about 750,000 people in North Mississippi, South Central Tennessee, and West Alabama. We're either the primary, secondary, or tertiary care facility for those people from a cardiology standpoint. And so we have a wide spectrum of patients that we see. The biggest thing is that Mississippi is a state where cardiovascular disease is #1. Unfortunately, we are one of the more diabetic states in the nation. We're definitely the fattest state in the nation, and we have one of the highest risk of cardiovascular death in the nation. And so when I talk to you about these patients that I see today, just understand the high risk nature of the folks that we see in this area. Next slide. So backing up a little bit, sort of talking about my journey as we got into using closure devices. To be honest with you, we have a lot of these high-risk patients, and they do have an increased risk of bleeding. So I was sort of desperate in my journey to try to find something that worked. And honestly, I did try just about everything. We did try Angio-Seal, and we later called it Angio-Squeal, because most of the patients really felt that. We also were in the early stages of Angio-Seal, where we had a lot of the foot plate disasters, where we would have acute thrombosis of the leg from the Angio-Seal foot plate. The per-close device, again, if somebody had any kind of peripheral vascular disease or it wasn't a pristine stick, that wasn't really a very desirable technique, and it does take some time in order to deploy the per-close. We did try star close and had some great successes with that, but then we started getting feedback from our vascular surgeons. They didn't really like how we littered the landscape with metal in the leg, and then there are those occasional star close failures, and sometimes you don't recognize those failures right away. And then we did use minks a good bit and bailed out on minks after we've had some unfortunate deployments intravascularly and had to go fish out the gel out of a leg or two with that. So up until the time that we got Vascade in our hands, we didn't really find that a lot of the vascular closure devices were very sufficient at all. They seemed to have great limitations. They weren't generalizable amongst a broad spectrum of the population. And so because of that, we had shelves with everything on it. And so that it was a big problem. The other thing I think it's always important to think about when we think about patients that were closing their leg during the procedure, they're sedated. They don't necessarily know what we're doing. I could be the best doctor or the worst doctor in the world, and they don't know that. The only thing that they know is when they wake up and they look at their leg, if they have a big hematoma or their leg's purple, then they're going to remember that. And that's how they're going to talk about me as their physician. And so, that closure does make a lot of importance. Next slide. So as we think about the Vascade, why I wanted to jump into the Vascade is that I looked at the RESPECT trial. And then I was going to quote something out of the RESPECT trial that I think is very important, and we'll get back to that a little bit. A sort of a setup in the RESPECT trial write-up. It said vascular closure devices have not been shown to have greater safety than manual compression. So that was the premise up to that point. So all of these closure devices that we have talked about, and we'll show you a slide in a moment to deal with that, none of those actually have shown any better than manual compression. But in the RESPECT trial, at the very end of that, the conclusion is with VASCADE, there's a substantial reduction in the minor complication rate as compared to manual compression. Now, in this particular trial, to be honest with you, there were no major complications. We'll again discuss that in a moment. But when we think about those minor complications, that adds up, and then that affects the throughput of patients as they move through. So let's say that I did manual compression and we're 2 hours into it and the guy rebleeds. Well, what do you think happens? Well, we go back and we hold manual compression again, and guess what? The time clock starts all over again. And so that patient, instead of being discharged at 3 hours, now is discharged at 6 hours. And so that's longer that they're in the hospital or the observation room, and that adds up to money. So VASCADE also not only is it got this great data, but it's simple to use, it's simple to deploy, it's a versatile product. I can use it in a variety of different circumstances. It's extravascular. I'm not putting anything inside a blood vessel. There's no foot plate in there. There's nothing I need to worry about. There's nothing permanent left behind. I don't have sutures left behind. I don't have little metal clips left behind. And so my vascular surgeons aren't going to yell at me. And importantly, this device is not painful to the patient. And then again, it's not that angio-squeal kind of scenario with this, is that this is a comfortable device for the patients to receive, even if they're wide awake, that they tolerate this quite well. So when we think about the Cardiva device here, it does have this nitinol foot plate. The nitinol foot plate is easy to see under fluoroscopy, and this helps with positioning, as we'll show in a moment. And then when it is exposed and the device is deployed, there is a collagen patch which grows 13-fold, and that's an extravascular patch. And then that seals up the blood vessel, and with that we get rapid hemostasis. But importantly, this is an extravascular closure device. And then with this, I can also use my procedural sheath, and I'll show you some examples of that in order to get that closure. Next slide. So there are two products that are available right now in the market. And I sort of look at them as small bore and large bore, but we have the VASCADE, which can close arterial or venous sheaths at that 5 to 7 French in size. And then we have the larger bore, the VASCADE MVP, which is on label for venous procedures, 6 to 12 French in size. And we'll show you some data that and some examples with regard to the VASCADE MVP. The next slide. So again, when I look at my practice, I can see that I use the VASCADE MVP or VASCADE small bore device in just about all of my femoral cases. There's almost nothing that I really exclude in that. So I'll show you some examples here of closing both arteries and veins. This is going to be in regular coronary cases. We're doing interventions. This can be peripheral cases. I'll show you some antegrade sticks. When we do right and left heart cath for diagnostic procedures, we use this routinely in our TAVR cases in order to close the small bore access. And then also I do a congenital heart work, and when we do ASD closure, is that we will use the VASCADE MVP to close those larger bore venous access. So we'll discuss some examples through that. I'm going to hammer on this point a little bit later, but I think one of the key things with VASCADE is that in particular when we got into the performance guarantee, it really made us pay attention to access. And so when we started using Vascade, we started paying a lot more attention to our access. And so with that, we would fluoro the head of the femoral neck there in order to know our landscape. We began to use more ultrasound guidance. We used micropuncture access. We would take fluoroscopic imaging of the access site to make sure it was a proper and appropriate stick. And with this, I think that this plays into not only the good access, but it allows good closure. And so I think that when you move forward in there, in a program, or if you're going to another institution, have them pay close attention to their access, pay that extra time into getting good access, because then that's going to yield great success when we talk about closure in the future. So next slide. So in this particular next setup here, this is in a TAVR case. Just to give you a little bit of a setup, behind my hand in a moment, you will see that there is a surgical tech who is holding pressure in the right groin. We have already done crisscross perclose on the right side to close our large bore access for our TAVR procedure. In here, I'm going to close our venous and small bore arterial access in our TAVR procedure. I'm first going to close the vein. As you see, I'm going to pull back a little bit on the venous sheath before I deploy the disc. And then we're going to then deploy the Vascade device. And then after I deploy the Vascade device, what I'll often do at that point is to go ahead and apply the clip. And with that, that allows that, because it's low pressure, some time for there to be some dwelling, the collagen to expand, and then get that adequate closure. And remember, this is a fully anticoagulated patient in order to do this TAVR device. So here I've deployed the arterial device. Then I'm going to have my tech come over. She's going to put her hands for light hemostasis, and I'm going to do the double click and pull. And with that, she's going to hold pressure for about 5 minutes, and then we're done on that side. So just like TAVR, going on to the next slide, we do the same thing when we're talking about when we do right and left heart caths. And so again, when we do these, we're going to close the vein first. And so here you can see the orange 7 French sheath from where I've done a right heart cath. We're going to place the device. I'll pull back a little bit just to expose the disc, and then I will deploy the disc. And then after I tamp down the collagen, apply the clip, and then I move on then to the arterial closure. And then after I get the arterial closure set and in place, then the tech will then come and I'll do this double click and pull. And then they'll hold pressure for 5 minutes, and then we're looking good after that. Next slide. Now, as I mentioned earlier, we do some congenital disease, and so this is a patient in which I have now done an ASD closure. In these procedures, we usually have an 11 French sheath on the right side, maybe a 10 French sheath on the left side. This allows us to do intracardiac echo as well as to deploy the device. Early on, I will tell you is that I would take out the large bore sheath, replace it with a small bore sheath, allow for some vascular recoil to occur, and then deploy the Vascade MVP. I will tell you there has been an iteration of the Vascade MVP where the disc is a little bit more sturdy. And so I don't know that you have to downsize to the smaller sheath, but I found this to be successful and to prevent any kind of pull through. So as you'll see in this video, On the right side, we're going to exchange out for a small sheath. And so I'm taking out the 11 French sheath. I'll exchange this then for a 6 French sheath. And this has usually been the sheath that I've used for access. And then after I get the 6 French sheath in, now I'm going to go in with the Vascade MVP. And then my tech at this point has been wetting the tip of the Vascade MVP to go ahead and allow it to begin some swell. And so similar as we talked about with the venous sticks on the other side, you're going to see me go ahead and clip the blood vessel here, and then just leave that in place. Again, allowing the collagen to swell in this low pressure environment. And so now I'm moving to the left leg. This is a 10 French sheath. We're going to remove it, exchange it also now for a 6 French sheath. After I get the 6 French sheath in place, then I will exchange it for the MVP. We have our tech always sort of deploy the disc before we go out to make sure that the disc is round, and then they go ahead and then after they've retracted the disc, then go ahead and dip the end of it in saline, and then they hand it to me. So that bit of a delay in between these procedures is them dipping the end of the Vascade device. And so now the tech will come over in a moment. So the biggest part of this is me waiting on them. If you see the time clicking by here. So they're gonna go ahead and grab both, double click and pull. And she'll hold pressure for 5 minutes and then we are good to go. This has been a game changer when we've talked about our throughput. It used to be, prior to me being able to do this larger bore venous closure, these patients would usually spend the night in the hospital because they'd have to wait for the heparin to be removed out of their system. Then we would do manual pulls and they'd have maybe an 8-hour bed rest. With this, these patients are actually able to go home after an ASD closure in 3 hours. And so this has been a huge game changer. The patients absolutely love this. All day. It's been great from the hospital standpoint, just throughput and being able to turn over the beds and not have patients in the hospital. Next slide. One of the studies that I was able to be a part of, or not part of, but I reviewed earlier, was this RESPECT trial. And in this, I mentioned earlier, is that there was this decrease in complication rate. And so as the major complication rate in this particular trial was not that great, the minor complication rate was 1.1% with Vascade versus 7% with manual compression. And of note, this is the only, then and now, the only marketed closure device proven to reduce complications and improve the workflow compared to manual compression in a randomized clinical trial. There was a significant reduction in the time to hemostasis, the time to ambulation, and the time to discharge from the observation room or hospital. And so this was very, very important findings. And as we move on to the next slide, we can look at other devices, and this is what they reported, is that you can see, number one, a lot of major complications. We can say that generally there are some major complications with manual compression at 0.2%. This is looking at that dark red color. But if you look at the other devices, Angioseal, Perclose, Starclose, Minx, there are all major complications that occur, and those major complications are occurring at a rate greater than manual compression. And so again, in medicine, we have this thing, first do no harm. Well, here we're actually doing harm. But flip down here to Vascade. We're not seeing any of the major complications. And then if we look at the pink, we're looking at the minor complications. We can see a substantial reduction in minor complications And then on the flip side of this slide, you're seeing that these patients get quicker hemostasis. So that means less staff time in order to achieve that hemostasis. Then you see that the time to ambulation is much less. And as that time to ambulation is much less, with that, you have greater throughput through the outpatient areas. Next slide. As I started to say earlier, we had the pleasure of taking part in the Antegrade registry. With this was really more of a peripheral vascular disease registry where we looked at patients in which we do an antegrade stick. So typically when we get access to the femoral artery where the needle is aimed up toward the heart from the leg, and we get that access going that direction, so sort of a retrograde access. In these, the access is aimed down toward the foot. So we're at the femoral artery aimed down toward the foot. Now, again, we're getting this access because usually these patients do have significant peripheral vascular disease. The peripheral vascular disease is down in their leg or their knee area there. And so this is a bad disease complication area. And usually these patients have comorbid issues that make us have to use that antegrade access. And so this was an ambitious study to begin with. As you can see in this particular study, 98% procedural and device success, 83% of their patients are ambulating less than 5 hours and 88 discharged in less than 8 hours with a very low risk of complications. So next slide. If we look at our data here, and there's only really 4 studies that have actually looked at closure of antegrade access, we can see that on the bottom graphic there, we can see that the patients that were complication-free with Vascade, 96.2% compared to 90% with Angioseal, 89% with Exoseal, 92% with MINX. And I think this is important. So why are we closing the leg? Number one is that we're trying to get the patient in and out of the hospital faster, but also we don't want the complication. These are already very complicated patients that we don't want any more complications as we try to attend to these people. So as we move on to the next slide, we'll give you some examples where you can sort of get a pretty decent idea about the complexity of these patients. So again, just to sort of as a setup, again, we're getting access at the femoral artery. We're aiming down toward the foot. Sometimes that access can be somewhat tricky to get, particularly if the patient is obese. A lot of times we have to use vascular ultrasound to make sure that we access the common femoral artery in a proper location. After the sheath is in this, usually in the SFA territory, we will deploy the disc in the SFA. And then what I believe that you ought to do is to watch the disc be pulled back under fluoroscopy, that you get it to your access site. Then you know that you can deploy the collagen safely at that particular location. The nice thing about the Vascade device is the nitinol disc is malleable enough is that it can pull through some areas of peripheral disease, and so that you can actually get back to the spot that you need to get to. And I'll show you an example of that in a moment. So we'll go on to then the slides here. So again, just as a little bit of a setup, this is a guy, he's got Rutherford 4 claudication. So this means he's having pain at rest. He has had an aortobifemoral bypass. And so that means is that there's an artificial bypass that is hooked to his aorta that goes down to each of his legs. And so this is tied in at the femoral artery area. These patients are very difficult to go up and over. So in this particular person, he is having rest pain in both legs. And so on this particular day, I'm going to work on both legs. We're going to be bilateral antegrade access, then with closure. So in the first video, this is my access in the right leg. You can see that there's tight proximal disease. There's a stent that is in the mid portion of the SFA with some in-stent restenosis. So all of this has to be dealt with. And so in this particular example, we actually use drug-eluting balloon here. as a treatment. So in the second graphic here, this is the access into the left leg. You can see the diffuse disease that is in that proximal portion of the SFA. So with that, I'm going to have to pull the disc back through that diffuse disease and then get back into my access site in order to deploy the Vascade collagen. So next slide. So let's do that. So here in the first graphic, I do have the Vascade into the sheath. You can actually see the disc protruding at the bottom below the sheath. And then you can see me pull the disc back, and I can get the disc back all the way to the access site. And so I know that I've not deployed the disc inside the stent. I can see that. I can pull back the disc really slowly until I get back to the access site, and then I can deploy safely. In the second slide over here, just to point out, number one, the yellow arrow is pointing at what a star close would look like. And so when I tell you that the blood vessels can be littered, that's what a star close would look like. And so just as an example. And so again, in this particular graphic, you can see I've deployed the disc in the left SFA. I'm doing the pullback under fluoroscopy. I can assure that the disc comes back to the access site. And when I get back to the access site, there I know I can deploy the collagen safely, and I will get adequate hemostasis. And then in the next slide, this will be the look from the external view. So here I'm closing the left leg first. And so I'm placing the Vascade in. You can see the lights dim. I'm moving under the camera. And so I get the sheath positioned. I've now deployed the Vascade disc. I'm pulling back the Vascade and the sheath together, watching it under fluoroscopy. Once I've got the disc all the way back, then I back the sheath out. And then I will then deploy the Vascade on that side. The angle is funny because remember we're angling down toward the foot. So the angle is the opposite. Now, we'll say is that after on the antegrade, we hold pressure for closer to 10 minutes in these patients. And so this is a bit longer than the normal 5-minute hold. So again, we're going to close on the right side. So again, getting access. I'm looking under fluoroscopy. I'm there deploying the disc. I'm going to pull back slowly, making sure that my disc is retracted all the way back, going through the peripheral disease. After I get the disc all the way back, I'm able to then pull off the access sheath, then deploy the Vascade device. And at that point, then I clip it. And I've actually have our techs trained now where if I put the clip on, I can somewhat walk away at that point, and they're able to click and pull. And so that's what will happen after that. They will click and pull for me. So one of the particular advantages, I believe, of the Vascade, particularly in those people with peripheral vascular disease, is the fact that if I do a patient that has some peripheral disease, and so this is a person that we've done a left heart cath on, and you can see in this first video, when I take the access site shot of the leg, there is some significant vascular disease that exists within the external iliac. And so I know that once I deploy the Vascade, that disc is going to have to be pulled through that. So in the second video, I can watch under fluoroscopy as my disc gets pulled back, and I can make sure that it comes back all the way to the access site. And so I can make sure that we're not prematurely deploying the collagen intravascular, I can make sure I'm back at my access site before I deploy the collagen disc with that. And I think this is very helpful. So these, the nitinol disc, the visible radiopaque markers really help a physician as he's deploying this device in people that have challenging anatomy. Next slide. And then in this particular example, this is a patient that we've gotten access on the left leg. There's already been some iliac stents placed. You can actually see the stent under fluoroscopy. I think it's important in this scenario not to deploy the disc inside the stent. And so here you can see just below that stent is the radiopaque markers. So I know where I am located. And so now that I'm not in the stent, I can deploy the disc, and then I can do then that pullback with making sure that I'm not dragging that stent out of location back with me. So I can pull that the Vascade device back without fear that I'm going to damage the stent that is in there. So I think the design of the Vascade makes this very, very helpful in order to see what you're doing when you're deploying a closure device, particularly when there's challenging anatomy, such as an antegrade stick or peripheral vascular disease or peripheral stents that are in locations. Next slide. One of the things that we have learned about the Vascade, and particularly as we were talking about the performance guarantee, really almost some of this became stirred by this New England Journal of Medicine article where it suggested that registries would be able to provide an active surveillance of medical device safety. And so these registries were useful as a tool to make sure that we were using devices safely. And so that's really what the Cardiva performance guarantee stepped up and did. And so I'm financially incentivized to report my complications because the Cardiva will reimburse for my complications or reimburse the hospital to offset the cost of those complications. And so I'm financially incentivized to report those. And in that, I know when I have a complication because I'm reporting my own complications, but it also then makes me pay attention to my access. It makes me pay attention to our closure and to our technique. And I think that that's been somewhat lost. I've noticed that as the world has gone more and more radial access, is that the cath lab staff is less skilled at doing manual closure. And so honestly, while I showed you some registry results about manual closure, I bet that we're not as good as that anymore because there's people that are in the cath lab that has not pulled a sheath in probably the last year because a lot of sheaths are being managed radially. They get a TR band or their femoral access and they're getting vascular closure. And so manual closure is becoming a lost art. And so with the performance guarantee, we are looking at our access, we're looking at our closure, and we're looking at the outcomes. And with this, it's almost a continuous quality improvement technique. And we've actually used that to modify our technique. Do we do fluoroimaging? Do we do ultrasound guided access? Do we switch over to micropuncture? All of this is important for us to make sure that we decrease our growing complications. Next slide. In this cath PCI registry, it was important to recognize that 5.8% of that modern look back registry had a bleeding complication from their groin. 6%, think about that, 6% in a registry had groin complications and from bleeding. And that seems to be just obscene when I show you some numbers in a moment. So what is this performance guarantee? One is that there's going to be this partnership between the institution and with Cardiva Medical. With this, we're going to focus together as a partnership to reduce access site complications. Again, there is this incentive to report and report immediately because Cardiva, if there is a recognized complication, then they reimburse the facility, so that your facility would want to be reimbursed if there was a complication. This has been very easy to implement. It was like a one-page agreement. There's a one-page complication claim form. There's no protected health information here, so you don't have to go through all the legal mumbo jumbo. It's been pretty easy to develop. And with that, then we have feedback that actually comes from Cardiva Medical, that y'all give us a report card on how we're doing. And then we look at that and then we decide, do we need to change our technique, or how do we need to function differently? So next slide. So again, Roger had mentioned earlier that we had the pleasure of, and the opportunity and the honor of being the first hospital in the United States to participate in this performance guarantee. But now there's more than 100 hospitals across the United States that are now under this performance guarantee contract. With that, there's been 83,000 plus devices. Generally looking, there's less than a 0.1% complication rate. So what did I just tell you? Do you remember that number that was in the PCI registry? 5.8%. So everybody that's in the PCI registry, so we're quote doing it right. Oh, my technique is perfect. I never had the complication. You're the 5.8. Now I switch over to something where I'm paying attention to the access, I'm paying attention to the closure, I'm using a good device, and all of a sudden my complication rate is less than 0.1%. It's pretty impressive. And so what does that mean? That means we're decreasing around 4,800 complications, saving $23 million in potential cost savings. And so that's a huge amount of money when we're thinking about what has happened to these patients, this transition that's occurred. So next slide. When we look at our own data, so I mentioned to you earlier is that Mississippi is this, we have big, fat patients. We have a lot of peripheral vascular disease. We have a lot of diabetes. We have a lot of complicated vascular disorders here. So this is our story. So since April 16th, we've now put in about 5,000 Vascade devices. We've had 6 complications for a complication rate of 0.12%. And so nationally, the complication rate has been 0.08%. So it's less than 1 in 1,000 complication rates generally across the board. So I think that this is important when we think about a high-risk vascular complication or a high-risk patient subgroup. And so we have a 99.88% success rate. So I've made this comment before, if Mississippi can do it, everybody be able to do it. I mean, if we're number 52 out of 50 states, and that's where we sort of rank because they count District of Columbia and Puerto Rico. So if we're 52 out of 50 and we can do this, and then there's no excuse that every other hospital in the United States can't beat what we do. And so I'll throw that out as a challenge. If we're 99.88 in a horrible patient population, show us that you can do better. Next slide. So we looked at that and we actually published some of this information. And so this is a recent article that, that myself and Justin and Roger participated in. And what we looked at is overall looked at the performance guarantee, but then we also looked at our own numbers. And what we saw amongst our own practice is that we saw a 3% absolute reduction in our vascular complications. So that means 3 out of every 100 patients had no longer a vascular complication. With these vascular complications, they're roughly about $5,000 per complication cost to the institution. So if I have 3 out of every 100 that I avoid, that's 3 times 5,000, that's $15,000 that I've avoided in costly complications. Now, the other thing that we looked at is that we looked at our time and observation, and we found that these patients that got these closure devices were discharged 3 hours earlier than those that received manual compression. So as an average, 3 hours earlier that they went home. So within our institutional cost is $100 an hour. So if they're 3 hours earlier for all of these patients, That's 3 times 100 times 100 patients. That's $30,000. So for out of every 100 patients, we're saving about $45,000 in cost because we've gotten them discharged sooner. So we're not having the increased nursing costs to take care of those patients longer, and we're avoiding the cost of the complications. And so some significant impact on our side from an institutional standpoint. Next slide. So we did talk about that a little bit in some Cath Lab Digest articles. One we talked about from a medical standpoint, from the hospital standpoint, signing up for a performance guarantee. We found that this was really a sort of a no-brainer for an institution. If you're an institution out there and you're striving to get high quality care, this is the perfect setup for you, because it's going to allow you to monitor your growing complications when you're doing vascular access. How am I accessing the patient? How am I closing the complication? What is my complication rate? And with that is that from our institution is that we literally had a true partner. So this isn't like, oh, you couldn't deploy my stent, so I'm going to give you a stent to replace that. This is no, if you use our device and there's a complication, we're going to be in partner with you to manage that complication. Not just that we're going to be there for education, but we're going to be there and replace the device, which would be nothing. But we're going to be there to manage the financial risk of that complication to you. So you're standing behind your device. And the thing that is even more amazing is that when we looked at the clinical trial of the RESPECT trial, remember the complication rate, the minor complication rate? It was 1.1% in RESPECT, correct? Remember that? And so I just now showed you in their performance guarantee. So this is real world. So these are all patients that are coming to the table. So these aren't just the nice, healthy, compliant ones that you're putting in a research study. This is everybody. So in the real world, what's the complication rate? Less than 0.1. Now, how many times have you ever heard of the real life data being a logarithm better than the research data? And still, that's what we have right here, is that this is amazing that we're seeing that the real world application through close attention to access, close attention to closure, and using the Vascade device is that we are actually outperforming what a clinical trial did. And I think that this really speaks to the benefit that we're able to provide our patients when we use the Vascade closure device. Next slide. So again, in a summary standpoint, Vascade is an easy to use tool. I can use my existing procedural sheath. I can use the Vascade, no special sheath insertion required. I can use it in calcified blood vessels. I can use it to pull back through the SFA. I can use it in bifurcation lesions. I can use it in arteries. I can use it in veins. It is a very simple three-step deployment. It really takes no effort at all. You saw videos of how quickly they can deploy the Vascade, and so that it is not anything that's time consuming. Importantly, there's nothing left behind. If I needed to re-access this patient 2 days from now because I needed to go back in for another access, I can. Is that there's nothing that I'm prohibited from re-accessing this blood vessel immediately. I can get right back into it. I don't have to worry about metal clips that I have to avoid sticking through. I'm not going to get yelled at by my vascular surgeon because I've sort of littered the landscape in the common femoral area. And patients really tolerate this quite well. They tolerate it from a couple ways. Number one, they're not getting a lot of pain. But remember that slide I showed you with the major complication rate? They're not seeing all these purple legs. They're not seeing these big hematomas. And again, that's what they're going to remember their doctors by, is what does their leg look like? And so using this device has really made me look good for my patients, because when they wake up, their leg feels good. There's no hematoma. There's no pain. And then they're able to be discharged home successfully in a shorter time window. And so not only has the Vascade reduced my access site complication rate, it's improved our workflow so that we can get patients in and out of our hospital or observation areas quicker. And by getting them out of the observation area quicker, I can, on those busy days, really turn those rooms over, which really makes the hospital more profitable if I'm able to use those rooms twice throughout a day. And all of that is done through this financial risk sharing agreement. And so with this risk sharing performance guarantee, then it is this continual quality improvement process. And so not only me, but for every one of my partners, we look at our data and we look at it on a regular basis, and we can track how well are we managing these patients. And this is one of the metrics. I just reviewed our NCDR data with our registry in tech. And one of the things that is tracked on the NCDR, the ACC registry, is your bleed rate. And so they scorecard you on how you rank amongst your peers, your peer hospitals, on your bleed rates. And I think that's going to be an important thing that we all need to pay attention to, because as we shift to this quantity to getting paid by quality, this is certainly a quality indicator that we need to know about and pay attention to. Next slide. So before we move into some questions and answers, these are some disclaimers that are there for your review. And then finally, next slide is that this is some safety information, not only about the regular Vascade vascular closure system, but also the Vascade MVP, sort of that larger bore venous closure system. And so at this time, I'd be happy to answer any questions that you may have. And I appreciate your attention, and thanks for being here today. Thank you.
Thanks, Dr. Bertollet. That was fantastic, so thank you. Dr. Bertollet, there was a couple of questions that have been coming in, and you've answered a couple of these as they've come in, but just a couple to start out with as we collect any additional ones. One question came in that asked, do you close venous or arterial first on TAVRs? And can you share the thought process on venous versus arterial closure first?
Right. So I typically will close the venous access first. So I'll close it, and then I'll usually clip it to let the collagen have a chance to swell, because with the venous pressure so low, there's not going to be a lot of blood in there to activate the collagen to allow it to swell. And so I will allow that process to occur and then go ahead and then close the arterial access.
Okay.
And so it sort of sits and dwells, you know, maybe another 30 seconds longer, maybe.
Okay. I appreciate that. And you shared before to take note of hydration levels and things like that of patients that especially on the venous side. I know I've heard that from you before. Dr. Bertollet, the second one was regarding the antegrade discussion that you had. I'm going to potentially butcher or paraphrase this, but it said, question came in from Mark. It would seem like antegrade closure would be a shorter manual hold as the arteriotomy is angled away from antegrade blood flow. Am I missing something, or any thoughts on this, on the length of the hold for the antegrade?
Yeah. So a couple of comments. I'll just say a hole is a hole. And so I guess regardless of the angle of the hole is still there, and we still have to close it. The other thing to really remember is that these are a lot more complex patients. They do have advanced peripheral disease, and the longer hold is just because there's just that much more disease in the blood vessel there. Now, honestly, you probably could get away with a shorter hold, but when we were initially thinking about the antegrade study, and several of us from around the country sort of looked at this, we thought that maybe investing that additional 5 minutes in these patients was probably a good investment, just to make sure they didn't have a complication there. Remember this, is that if I let's say that I accessed the right leg and I went up and over and I did some work on the left leg in a regular patient, and then I came out and I had a groin complication on the right side. Well, then my bailout would be to access the left side, come up and over, and then do the repair work that I need. Now, I just told you that some of these patients, they're not great candidates to come up and over. In fact, it's going to be close to impossible. So if that person had that aortobiofilm, is that my ability to do a repair of any kind of bleeding complication, so a covered stent or balloon tamponade, is going to be close to zero in those patients. So investing the extra 5 minutes to get it right the first time pays off big dividends.
Okay. And Dr. Bertollet, when we were doing the integrated registry, as we were taking a look at those patients, the complexity of the patients based on the Rutherford score was much, I mean, it was pretty compelling as far as the complexity of those. Would you say, as a follow-up to that question, I mean, you know, something going poorly associated with the access site for those patients is even a greater impact, a greater negative impact for a healthier patient population, if you will?
Yeah, absolutely. So a lot of times if you had that groin complication, is that even if you were able to come up and over and you did some balloon tamponade, you're not tamponading a normal healthy vessel. You're trying to tamponade a diseased blood vessel, and it's just not going to close as well in those patients. And then you're likely going to have to put maybe a covered stent in this area. And again, that really what you want to do is put a covered stent there. So that's going to be tough.
Okay. Dr. Bertollet, I think that you answered this one, but one of the questions that came in is, do you routinely ultrasound all patients, and or do you routinely utilize micropunctures for all your access?
So two questions there. Number one is that we do routinely use micropuncture access for all arterial and venous access, and we actually do an angiogram of the access site. Now, part of that is twofold. Number one is that in the performance guarantee, that's part of it, to make sure that you have achieved adequate access. And so I mentioned earlier how, being part of the performance guarantee, we changed our process. And so the process for all of my interventional physicians is that we use micropuncture access, and we do an angiogram of the access site through the micropuncture sheath. And then if we're not happy with that access, then we can always change it, and we don't have a big hole to have to contend with. That's number one. The use of the ultrasound is not 100%. Sometimes in patients, you can use fluoroscopy, identify on the femoral head well. If they have a lot of calcium in the blood vessel, you can actually see the blood vessel under fluoroscopy, and so it might be a direct access that direction. But we're always using micropuncture to make sure that we don't create a big hole before we're sure that we have a good access.
Okay. And Dr. Bertollet, you talked about the risk-sharing program. One of the questions that came in was, how has your group viewed the risk-sharing program to improve awareness in your facility regarding complications? I think you pointed out, and you track it, you saw a 3% reduction in complications, a 3-hour earlier ambulation, and I think 45,000 in cost savings per 100 patients. So I think you answered that, and I wrote down the comment you made about the New England Journal of Medicine, the active safety surveillance program that was punctuated in the New England Journal of Medicine article. So I think you already answered that during that, but the question that I would ask is, we get this a lot, and you and I have had these discussions before. For people that are on the call who routinely come across challenges with legal or with cath lab directors, managers, who think there's a quote unquote catch, or they're missing something about this. Any feedback to someone who's supporting it, but for whatever reason there's resistance to actually signing up for the risk sharing program?
Yeah, and I think this is a key thing, and this is what's impressed me so much about Cardiva from the very beginning, is that there was never a catch.
Right.
This is all about quality. And then here's the important thing is that you believe enough in your device to stand behind it. You put your money where your mouth is. There's a lot of people out there talking about, I got the best device in the world, but they're not standing behind it like y'all are. And I think this is the key thing is that for those other hospitals and institutions out there, is that this is a fantastic device. Just look at the data.
Mhm.
Look at the published data. Look at the performance guarantee. Look at the RESPECT trial. Look at the Ambulate trial. Look at the Integrate registry. The data is out there. If you want to see scientific data, it is published. But then beyond that is that you're going to have now a industrial partner that will step up to the plate, not only do financial risk sharing with you, but help you in your quality initiatives. And so we all know that part of what our job has to be is to reduce bleeding complications. You don't have to be very smart to go to a cardiology program anywhere, ACC, anybody else, and half the lectures there about decreasing bleeding complications, because we know that when somebody bleeds, that costs a lot of money and it costs a lot of lives. It prolongs hospital stay. It leads to other complications. It can even lead to death. And so if we can avoid those, that's important. And so I think you as a partner, as a true partner, coming to us and saying, hey, you know, we want to take this challenge on with you. And I would just tell people that maybe just have to have a little faith that maybe there are good people out there. We're good people.
I think we've had that commentary internally as well as externally multiple times on this, because we commonly get, when we share the data that you share nationally, commonly get the underreporting out there, and we know there's underreporting out there, but that's kind of part of the program. It's more of a statement than a question. But how do you respond when people ask you, is there underreporting in your facility or nationally?
Well, I would say is that the underreporting, I would almost argue that there may be overreporting.
Okay.
Because our cath lab manager is that she's looking at all of these patients that come in. She's saying, oh, did they get a Vascaden in the blood or whatever? And she's looking at all of that, and then she's she's looking at trying to say, did we miss somebody? Did somebody bleed? Did somebody have a complication? Because she's having by her bosses to make sure that we collect the financial risk share if it is a true complication. So I'd say is that she's quite vigilant looking for those complications. And I'm very proud to say is that 99.88% of the time she can't find anything. And in those patients that have had bleeding complications, when we go back and we review them, oftentimes those are the manual compression patients that for whatever reason there was not a closure device placed. And then that is something that while we didn't use Vascade because we're in this performance guarantee, we're going and reviewing all those patients. Then we go back and we do re-education on manual compression. We go, talk to the nurses about, okay, you know what, we had a complication here. We need to review the process that you went through to pull that sheath. What was their blood pressure like? How long had they been off their anticoagulation? Did you check an ACT first? I mean, we go back through that process to make sure it doesn't happen to the next guy. So even though it wasn't your product, is that because we're involved with your product, is that helps raise sea level for everybody. And I think that's important.
And I think that dovetails on the last question that we had was, why use Vascade or any vascular closure device on veins versus a purse string or figure of 8 suture? And I think you could.
Yeah, I groan because you would not believe and these are sort of gross images sometimes, but my patients will send me pictures of their legs after they've had a figure of 8. I'd say that my EP doctors in the past have really liked that figure of 8, and they can just throw it in there. But oh my gosh, is that I've seen so many complications that have occurred from those. So those complications can be a couple. Number one is if you took too big of a bite, you're going to get into the artery, with the needle. So I have seen some pseudoaneurysms. I've seen some focal dissections because of a big needle bite there. I have seen some proximal DVTs because then they tied off the vein and they left it tied off too long, and now you got a proximal DVT that you got to deal with.
Okay.
But a lot of these patients end up having bleeding complications anyway. And then that's mostly what I get feedback from, is that they have these huge purple, ugly looking groins and it tracks down their leg. And the unfortunate story is I got a lady right now that's one of my patients that has gone through one of these figure of eights, and she's been going to wound care for the last 3 months, dealing with her leg complication. And so this particular lady, again, she had an EP procedure, a large bore catheter, figure of eight. The EP procedure went perfect. No issue there at all. Guess what she remembers? The only thing that she's aware of is her groin complication in her 3 months now of dealing with the groin complication. And so it matters. The figure of eight, I don't think that we ought to be using that. I really don't. I think the complication rates are really, really high. And I can tell you that patients really don't like those.
Yeah, and that's what our literature search, as you pointed out, I mean, I think the data is out there. I think our literature search confirmed that as well, and we certainly agree. Dr. Bertolet, thank you for your time. Mike, we don't have any additional questions, but Dr. Bertolet, this was incredibly educational, and I really appreciate the time, especially in the evening like this. I'm glad that patients are coming back, and it seems like things are loosening up a little bit with access to care, and some of the things related to COVID over the last 12 months seems to be subsiding to a large degree. So thank you very much. I really appreciate it sincerely, as always, and looking forward to seeing you in person soon.
Well, great. Again, thank y'all so much for the time and the attention and the opportunity. Appreciate it very much.
Thank you. Mike, thank you. I think that's everything for us.
Yes, it is. Thank you for calling in, everyone. Thank you, Dr. Bertolet. Have a great evening.